Coronavirus is a family of viruses that causes respiratory infections. Most of those infected have mild symptoms, with approximately 15% progressing to severe cases, requiring hospitalization, leading to a mortality of about 3%, depending on the country. Even though it has a lower mortality rate than previous outbreaks like SARS and MERS, the spread of COVID-19 is faster due to the long asymptomatic period, when a carrier has a chance of contaminating several people. Epidemiologists estimate that the chances of COVID-19 reaching between 40 and 70% of the world population in the next 12 months are high, which puts immense pressure on the healthcare system as a whole, since critically ill patients usually require ventilatory support in the ICU for several weeks. In Italy, the healthcare system has an overload not seen in the last few decades. Operating rooms and other medical specialty beds had to be transformed into ICUs, and critical sedatives are out of stock. According to specialists, it is too early to talk about a vaccine. The goal is for people to resolve clinical symptoms, leave the hospital quickly, and to survive the infection. According to Professor Marcelo Amado, professor at the University of Sao Paulo, recent studies indicate that COVID-19 cases present hypoxemia, disproportionate to the radiological and mechanical impairment of the lung. Unlike swine flu, respiratory mechanics are good in the early stages of the disease, with very well preserved lung compliance, which generally results in low driving pressure. And here there is a paradox. As the hypoxemia is profound, due to a great failure of hypoxic vasoconstriction, the caregiver ends up rushing and using very high pressures, PEEP, in the ventilator, resulting in hemodynamic impairment and organ failure, leading to a vicious circle that often results in death. It is at this point that individualized monitoring and the use of protective ventilatory strategies make the difference. The individualized monitoring supports safe and effective ventilation while providing visibility, precision, and individualization at the bedside to benefit clinicians and patients. In dealing with similar cases, the use of individualized monitoring suggested that patients need a PEEP reduction, and this need was absolutely counterintuitive in view of ongoing severe hypoxemia. Surprisingly, the PEEP was lowered, sometimes at levels below that recommended by the PEEP FiO2 table proposed by the ARDSNet network, and the result is that all patients showed an improvement in mechanics and gas exchange, in a paradoxical effect, but very beneficial to patients. Also, according to Professor Amado, another frequent problem in this condition is the use of non-invasive ventilation without adequate monitoring. Here also, electrical impedance tomography can be used to identify problems in the dynamic and distribution of ventilation, so caregivers can identify earlier those patients who need invasive ventilation and muscle paralysis, avoiding another vicious circle where the patient's own breathing efforts end up causing pulmonary inflammation.